Good morning. As you can see, this session is titled Second Opinion. The doctor will see you now. How many of you have gotten a second opinion from a Waldenstrom's expert? Raise of hands. Wow, that's quite a few. Well, as you probably know, most of our local oncologists aren't real familiar with managing Waldenstrom's. So the IWMF recommends that patients who are newly diagnosed seek out the opinion of a Waldenstrom's expert if they can. And sometimes when your case becomes very complex and you're not sure what the next step would be, that's also a good idea, a good time to check out a Waldenstrom's expert. So today we've assembled a distinguished panel of oncologists who are very experienced in managing Waldenstrom's. And to learn more about a rare cancer, I'm going to present them with some case reports and ask what their recommendation would be for these patients. Our panelists are Dr. Stephen Ansell from the Mayo Clinic in Rochester, Minnesota, Dr. Shirley from the University College Hospital in London, and Dr. Sheeba Thomas from MD Anderson Cancer Center in Houston, Texas, and Dr. Judith Trotman from Concord Hospital in Sydney, Australia. So our first case is a gentleman named Dennis, and he was diagnosed with Waldenstrom 6 months ago at the age of 61. He's negative for the MYDA88 and CXCR mutations. His abnormal lab findings are IgM 4400, IgG 11,000, hemoglobin is 11.5, his white blood cells are 2,000, and a neutrophil count is 1.4. He was recently hospitalized for pneumonia. His local oncologist has recommended treatment with ibrutinib and rituximab. Dennis wonders if that's the best treatment for him. Who would like to begin? Dr. Ansell, you've got the microphone.
Firstly, just to say, the thorn among the roses, maybe. So I do just want to reiterate the importance many times, if there are questions in your mind about diagnosis and therapy, it's really reassuring when other people do an evaluation of your case and provide you with either complementary or additional information that really empowers you moving forward. So to get to Dennis here, there are a few things that are really interesting to me about this case. So you've been hearing a lot about Waldenstrom's macroglobulinemia and that MYD88 mutations are very common. So this patient does not have an MYD88 mutation. You heard about CXCR4 mutations, which are common in about a third of cases. This person also doesn't have that. And then they have pretty much across the board lowish hemoglobin, low white cells, and lowish neutrophil count, and a problem with infection. And on top of that, this elevated IgM at 3,400. Just important to know that IgM can be high in other cousin diseases to Waldenstrom's macroglobulinemia. So I would actually say that in this case, we need to just be sure about the diagnosis before we jump into how to treat. Because there's a very similar disease that is called splenic marginal zone lymphoma that can look very much the same under the microscope, and usually, and only 10 to 15% of the time, are they MYD88 mutated and may not be mutated. So in this case, the fact that the person has lowish blood counts across the board, I would love to examine them and see if their spleen is big. If the spleen is big, I would be much more likely to call this splenic marginal zone lymphoma than lymphoplasmacytic lymphoma or Waldenstrom's macroglobulinemia. I would say this much, that those diseases being similar respond very similarly to the same agents. So you can use ibrutinib with rituximab in that disease. But I think important in this case would be to actually work on the diagnosis and be sure you're right. I don't know if others want to comment or have any other thoughts.
So I guess as Dr. Ansell was mentioning, so there was a study called Innovate that looked at ibrutinib rituximab and compared it to rituximab alone. On that study, there were a small number of patients who, like Dennis, had MYD88 wild-type disease. And in about 73% of those patients, granted it was a small number, did respond, who were MYD88 wild type, did respond well to the combination of ibrutinib and rituximab. So that, I think, supports, even though it's a small number of patients, it at least supports the regimen that his oncologist is recommending for him. I think it's also helpful to look for why he's neutropenic, why the white blood cell count is low. In addition to looking at the spleen, is it because the marrow is quite full, or could it be that he has a vitamin deficiency, for example, in B12 or folic acid that could easily be corrected that would help remedy that white blood cell count, even partially?
So I, I reiterate what Steve has said about the diagnostic issue. The other thing to remember is that depending on the method used, you may miss some MYD88 mutations. So I think one would need to just check what method was used, because then he may actually be MYD88 mutated. And in terms of treatment, I think he's quite young. Well, he is young, actually, 61, sorry. I'm old, I can't read. So I still feel that there could well be a role for chemotherapy and rituximab here, frontline. But I'd be curious to know what Judith thinks.
I'm with you, Shirley. I am presuming this gentleman doesn't have a marginal zone lymphoma and doesn't have an enlarged spleen. Firstly, I would do nothing for a little while. I want to make haste slowly. I want him to recover from his pneumonia, see how his albumin recovers, see what happens to his ferritin after he's recovered from his pneumonia, make sure he's not iron deficient. And then when it came time to treat him, I would be talking to him about having treatment with rituximab and bendamustine. Because for me, for someone who's 60, we're definitely playing the long game. And he, the Innovate study, the zanubrutinib study, we're confident about the 4-year outcomes, but beyond that, we're not as confident. So I want to give this man, provided he's fully recovered from his pneumonia and albumin's up and ferritin's good, I would proceed to bendamustine and rituximab, all 6 cycles.
Wonderful, thank you. Next case, please. So this is Edna. She's 80 years old and she resides in a nursing home. She has a history of high blood pressure and occasional brief episodes of atrial fibrillation. At her Waldenstrom's diagnosis, her hemoglobin was 7.5, IgM 6,200, and she's positive for the MYD88 mutation. She declined chemotherapy and started on ibrutinib, and she achieved a rapid IgM reduction and an increase in her hemoglobin. But she had a severe infection and the ibrutinib was stopped. So when she restarted the ibrutinib, she developed persistent atrial fibrillation. She continues ibrutinib with anticoagulation, taking Eliquis, and her daughter has asked her to consult with a Waldenstrom expert to be sure she's getting the right treatment.
Shall I start with this?
Sure.
Firstly, I think Edna is a superwoman. I mean, look at her. At 7, I can't remember how long ago, how old she was when her WM was diagnosed, but she managed a hemoglobin of 7.5 and IgM of 62. She's pretty hardy. Now, having started her zanubrutinib, I have to say I don't stop zanubrutinib during periods of infection.
Mm-hmm.
I keep it going, and there are a few reasons why. Firstly, because I don't believe it really impacts on the outcome of the infection. I don't have strong data that supports that or refutes that, but also we know that a good 10% of patients on BTK inhibitors, when you stop their BTK inhibitor, they will have like an inflammatory-like syndrome where they do feel quite, have high fevers, high inflammatory markers, body aches, and feel quite unwell. So I wouldn't want to, risk that. And I would be happy with her taking her zanubrutinib with her apixaban and reassure her and her daughter that her current doctor is doing just what I would be doing.
So I think she's responding to the zanubrutinib, which is good. She has acquired a complication, and that's led to the addition of an anticoagulant. Together with zanubrutinib, that will increase her risk of bleeding. So we need to be cautious going forwards. However, if the atrial fibrillation is manageable, controlled, sometimes the addition of something to control the rate can be added in, then I think one needs to persist with that. But you could consider a lower dose because she seems to have responded of zanubrutinib. She's responded pretty briskly to the treatment. So she may actually continue that with a lower dose and just be safer. But I would stick with her.
Surely it'd be great if we have a bit of debate, wouldn't it? But surely she actually had atrial fibrillation even before she started. She had brief episodes of atrial fibrillation. So odds are on that as she gets older, she was more likely to have longer episodes of atrial fibrillation. So, I think, wasn't there the study with the dose reductions with the ibrutinib that it doesn't really change the cardiac impact in terms of resolving the atrial fibrillation. So if she didn't have any, I think your points about the bruising and bleeding are very relevant. If she didn't have too much bruising, superficial bruising on the zanubrutinib before she had the atrial fibrillation and after she started the apixaban, I would just keep her at the same dose. But
I think getting back to the bleeding risk, because she is 80 years old, there are dose reductions for Eliquis in the setting of kidney issues or very low weight. So I would consider reducing the dose of Eliquis, of apixaban, to half dose, taking those into account. I would also make sure she's not on other blood thinners like fish oil, or if we can avoid aspirin Plavix, things that are going to increase her bleeding risk on top of the risks that are already present with the Eliquis and the zanubrutinib on board. I'd also take into account her risk of falling. If she is at high risk of falling, then zanubrutinib may not be the best choice for her. And then if she wants to avoid chemoimmunotherapy, maybe think about venetoclax.
Just again to agree with everything that was mentioned, we get quite a lot of people referred to us because they've developed atrial fibrillation to say, should they stop the drug? And I think as you were hearing from everybody, when you've got atrial fibrillation, it's like, you don't need to be concerned at that point. You just need to control the atrial fibrillation and you can continue on the zanubrutinib. The other thing, and again, just agree entirely about optimizing the bleeding risk. The other thing that I think is really important in this patient is what do the other immunoglobulins look like? So she had this infectious episode, are her IgG levels in the basement? Because that sometimes happens when you make a lot of IgM, you stop making the other ones. Or when you're on a treatment like zanubrutinib that shuts off your cells that make those proteins, then they drop into the basement. If that's the case, one of the things going forward that may help this patient a lot is replacement through an IVIG or intravenous immunoglobulin. You're basically giving the person somebody else's IgG as a way to prevent them from getting infections.
Thank you. The next case, please. Marie was diagnosed with Waldenstrom's 5 months ago at age 27. She's currently being treated with bendamustine and rituximab. Below normal neutrophils delayed the fourth infusion for 2 weeks, and her neutrophils are now at the end of the normal range. She's recently developed thrush and is questioning the need for continuing treatment because she's concerned about immunosuppression, and she's had a very good partial response to B&R at this point. She's also wondering if she's a candidate for stem cell banking, which her local oncologist hasn't mentioned.
So I think the question about stem cell banking is a very good one, especially given her young age, and I would strongly encourage her to have that done. As far as the bendamustine rituximab, ideally, I think she would get the 6 cycles of therapy. But there are some conflicting studies. So there was a study from Japan that looked at 4 versus 6 cycles of bendamustine rituximab, found equivalent results. There was a French study that looked at bendamustine rituximab and they compared patients who got all 6 cycles as planned versus those who had fewer cycles. They also found similar results. I didn't see the average number of cycles that they actually got in those who had fewer cycles, but some of those patients even required dose reductions in addition to the fewer number of cycles. There is, however, I think still another study which showed that there was some reduction. I think Judith knows a little bit more about that third study. We were looking at that before. Oh, maybe you do. Oh, sorry. Go ahead.
Yeah, so our group, we did a multi-center review of bendamustine rituximab, and the total doses used in so it was across a few countries, and I think it sort of the implication was fewer doses can impact on progression-free survival, or i.e. when you next need, how long you'll be in remission. But it was a little bit different in the upfront setting versus the relapse setting. I think my view in this lady, who is very, very young, is first of all to be sure that she has WM, and just make sure we're on the right track, because that's a very, very young age for that. And despite all the studies, which, as Sheeba says, there's conflicting results, I would be a little bit nervous about giving a lot of bendamustine. I have seen, and again, it's a bit anecdotal, but quite a lot of personal experience with a lot of patients. Low antibody levels after bendamustine and rituximab is not infrequent. There is a concern about the development of what's called myelodysplasia, when the marrow doesn't work so well in the future. So I think bendamustine can leave a legacy, and the younger the patient is, the more I am concerned about that, because we are, as Judith says, in someone like this, we're in it for the long game. So I would almost wonder if there is an argument for achieving, assessing her after 4 cycles, and perhaps going on to a stem cell harvest, and even considering stopping there and doing a stem cell transplant as next line. But I openly accept that this is controversial, but that's my kind of gut feeling in this case.
So just to pick up on a few points that were made, firstly, 27 is super young for this disease. So just to be sure you got the right diagnosis. Kind of a little weird that really struggling with blood counts at a 27-year-old. We often will sequence the bone marrow and look for other kind of clonal abnormalities to say, is there some other bone marrow problem lurking in there that's being uncovered by chemotherapy? Because that's really important, especially when we're talking about putting away stem cells for later use. If there's an inherent problem in the cells, then we may consider an alternative. Definitely would put away stem cells if there wasn't a problem, because 27, there are a lot of years ahead, and we want all the options possible. We're trusting there's going to be a cure and never need them, but that's just putting something aside for the future. And in our practice, we are a little more liberal, if you like, in how many rounds of bendamustine rituximab we'll give, because the goal is controlling the disease. This patient's already got great control. The goal is not hurt the patient. So sometimes when you get into the last 2 rounds, and Dr. Desai did a nice job of summarizing, Dr. Trotman as well, data that's out there, there is a fair amount of data that if you have a good response after 4 rounds of bendamustine and rituximab, the merits that you get from those last 2 rounds are pretty modest. So you got to be a little careful that you didn't pay a big price for long-term toxicity to squeeze in 2 more rounds that you may or may not have needed so much. So I guess in my view, in this patient, I would stop after 4, see what's the maximum that you can get out of the treatment, and then revisit at a later time other therapies. You're playing the long game, as you were commenting before.
Yeah, I would still like to try and get the 6 cycles into this very young woman. Her neutrophils are below normal after or delayed the 4th infusion. So it's not after the 4th. So she's actually only had 3. I'd really would like to, because she is so young, like to push through with dose delays and GCSF support. And like all of my colleagues, we agree that we would want to collect cells for stem cell banking. I'd like to make sure I collected a lot of cells just so in case I had to do an autologous stem cell transplant, or in case she goes to CAR T-cell therapy and has significant cytopenias, because I have, salvaged patients after CAR T-cell therapy with severe cytopenias in the past with stem cell reinfusion. So I'd want to make sure we had a lot in the bank for this woman. But like all my colleagues, we want to be absolutely sure she does indeed have Waldenstrom's.
Thank you. Next case, please. Bob is 58 years old and has a 15-year history of Waldenstrom's. He initially presented with anemia and was found to be MYD88 positive and CXCR4 wild type. He was treated with chemoimmunotherapies in 2007, 2010, 2011. He was stable following his last treatment with bendamustine until 2020. At that time, he was diagnosed with Bing-Neill syndrome and began ibrutinib. He required a dose reduction due to side effects, but was stable until January 2024. At that time, his hemoglobin began falling, and in the ensuing months, he required 2 blood transfusions. A CT scan, PET scan, and bone marrow biopsy didn't reveal a more aggressive disease. Ibrutinib was discontinued due to persistent side effects, and now he's experiencing withdrawal symptoms. With his hemoglobin continuing to fall and the frequency of transfusions increasing, he's seeking a second opinion.
Shall I start?
Please.
So this is a patient that we see a lot of, and again, it's a good success story on the one hand, but a challenge on the other. So it's a real, delight that a patient is 15 years out, and we're looking to have that be 20 and 30. But you can tell the patients needed a bunch of treatment along the way. Bing-Neill syndrome, as many will know, is when you get cells that actually get beyond the covering around your brain and actually get into the brain tissue or into the spinal and the fluid around the brain. That's a complication that can be very devastating. So there is a little challenge here that if you have a patient on no treatment to keep that under control, there are other symptoms that may quickly present when you've removed that treatment, which aren't mentioned here. The problem I see here is even though the treatment was stopped because of potential side effects, the hemoglobin's going down, the patient needs transfusions. Something worries me that the bone marrow is not quite right. So I would typically do a bone marrow at this point because I want to know one of two things. Is it the Waldenstroms all come roaring back in the bone marrow, or is this what we call myelodysplastic syndrome? So this person's had a lot of chemotherapy. Chemotherapy can damage the bone marrow. That damage can result in other problems, but a transfusion-dependent person at this point would make me very worried for a myelodysplastic syndrome. They would do some sequencing and look at the genetics of the cells to see whether that was true or not. There are other things, but I'll leave it to the others to discuss what they see.
Yes, I agree. A bone marrow biopsy to search for myelodysplastic syndrome, having had 3 different lines, including chemotherapy. And then it's a bit hard to sort of crystal ball gaze if he did have myelodysplasia. But if he didn't have myelodysplasia, I'd like to understand more about what side effects he had that resulted in the cessation of the ibrutinib, and probably consider starting him on zanubrutinib as an alternative BTK inhibitor.
Okay.
So again, a young patient with a long history of Waldenstrom who's already had a lot of pre-treatment and now has BNS. I'm taking it he's responded to the ibrutinib, but he's now had to stop that. I would, in terms of the hemoglobin, other than what has been mentioned, I would make sure that he's not developed a hemolytic anemia, because that sometimes complicates this disease, and that the treatment would be a little bit, there would be a few things extra one could do. That would be doing a direct antiglobulin test, LDH, reticulocytes, those sort of things. I would also check iron levels and B12, etc. bone marrow, I think, is very important. And I too was thinking that after so much chemoimmunotherapy, maybe zanubrutinib may be the thing to do, because the side effect profile is a little bit different. Alternatively, consider something like Velcade base if he needs more treatment, or a clinical trial. There are non-covalent BTKIs and also BCL2 inhibitor. Sonrotoclax is coming through. There are bispecific antibody trials as well. And of course, kind of the ultimate is CAR-T. But yeah, those are the thoughts I had.
So it mentions that he had a bone marrow biopsy, but it didn't reveal more aggressive disease. So I read that as that meant that he didn't have transformation, but not that he didn't necessarily have Waldenstrom's in his marrow. That was one possibility as explaining his anemia. If it was the case, then that it is the Waldenstrom's itself that is taking over the marrow that is causing the anemia, it looks like he got 9 years out of the bendamustine that he got, if I read that right, from 2011 to 2020. And so he did get a BTKI when he developed Bing-Neal, but it wasn't that he wasn't necessarily still sensitive to the bendamustine rituximab. So I think that that might be another possibility. He could return to that.
How would you manage the withdrawal syndrome after BTKI withdrawal? Is there a way to do that?
I think steroids work very well. Prednisolone, maybe 20 milligrams, something like that, to help calm down the effects.
Do you prescribe
In this case, you could just restart a BTK inhibitor.
this
Best solution is to restart. But often, as Shirley says, we do need to prescribe a short course of steroid, because often patients need to stop for a full week because they're having major surgery. Or at least I tend to abbreviate even for major surgery to 5 days and 5 days. And the patients know, I will spike a temperature and I will start feeling ordinary on day 3. And often that coincides with, their surgery, and the surgeons go, oh, they've, got a post-op wound infection. They've got to go on antibiotics, no matter how much you warn them and tell the patients to warn the treating team. So sometimes just giving them a short course of steroids helps ameliorate that.
Okay. Thank you. Next case, please. Roger is a 65-year-old laborer who was diagnosed with Waldenstrom's 2 months ago. He reports increasing low back pain over the past year, and an MRI noted several spinal fractures. He has no other medical conditions and has not taken medications predisposing to osteoporosis. His IgM is only 600, but B2 microglobulin is 6.2, and serum albumin are significantly elevated. His hemoglobin, platelet counts, and LDH are normal. There is no evidence of hypercalcemia. He was positive for MYD88 and TP53. CXCR4 was wild type. He currently complains of persistent pain in his left hip region. An MRI revealed an osteolytic lesion in the left femur. A bone density scan revealed marked osteopenia in both hips and the spine. He is seeking a second opinion to determine the best course of action.
I guess I can start. So osteolytic lesions are not unheard of in Waldenstrom's, but they are uncommon. So I think it behooves us to make sure that it is indeed the Waldenstrom's that is causing the osteolytic lesion. So meaning a biopsy of that lesion. There is IgM myeloma, so a related condition that should be considered in this case, given that the presence of these bone lesions. But sometimes the disease is sort of somewhere in between. And so we have to choose therapy that's going to straddle treatment for Waldenstrom's and treatment for myeloma so that we can cover both cases. So in this case, if that's what we find, is this is Waldenstrom's, but sort of behaving myeloma-like with these lytic lesions, I would probably choose rituximab in combination with Cybor-D, Velcade cyclophosphamide dexamethasone, sort of as a a regimen that will cover both Waldenstrom's and myeloma-like disease.
I completely agree with Sheeba. Those are my thoughts too. But I would also want to know that there's no kind of high grade transformation going on because it's behaving quite aggressively. He is positive for mid-88, so that kind of goes against IgM myeloma. But as Sheeba says, and I believe that diseases really don't care about our textbooks and our classifications, and they do their own thing. So it could well be a hybrid situation. I think we need to treat him. I noticed that he's got a very low albumin and a raised beta-2 microglobulin. So that suggests to me that the kidneys are impaired. So I think that needs urgent attention. He needs intravenous fluids. We need to consider helping his bones with something like a bone strengthening drug, check his vitamin D status. He may well benefit from some steroids until we get clarity about his actual disease. He may benefit from radiotherapy. He could perhaps be at risk of fracture in that hip. So an orthopedic opinion, I think, is important. And based on all the results, then one would make a decision about the anti-cancer therapy plan.
Yeah, I agree. And I'm particularly keen on the results of what we call the immunohistochemical staining of his bone marrow biopsy to see what proteins the malignant cells are expressing. Are they expressing the CD20 protein that is so commonly expressed by the Waldenstrom cells, or are they expressing CD38, a protein expressed by myeloma cells, or perhaps both? I mean, we just need to, know what the protein expressed by the cells would help me decide what antibody approach to include with the chemotherapy approach. And I quite like, even whatever diagnosis I had, an approach like you're suggesting, Sheeba, that sort of straddled both diseases, because it is quite unusual. And I also kind of like, if my pathologist is not clear, we encourage our pathologists to say either or, so that I can use one when I want one drug on a clinical trial later down the track, because they've got that label, rather than the other disease.
So I don't have a lot to add because I think all of my colleagues here have given good advice. This is an uncommon case, extremely uncommon. So talking to your pathologist matters because the pathologist needs to give some guidance here about what exactly is going on. Mm-hmm. The other thing that I think is really important, and you heard a little bit about this, but I just wanted to reiterate this, the patient's symptoms are his biggest concern right now. And making sure that the patient is not imminently going to fracture his hip is a key thing. So Dr. Desar mentioned about an orthopedic in consult, maybe radiation treatment, maybe if needs be, depending exactly where the lesion is, an orthopedic intervention might be needed because, again, it's about the patient as much as it is about the diagnosis.
What is the significance of the TP53 mutation?
Well, we should have Dr. Aberkoon come up here and tell us all about that, right? But again, I think the importance of that is it just explains why his work is so central. Mm-hmm. This is a weird case, and it's probably a weird case because it has a TP53 mutation. So he told you a little bit about this, but I kind of joke and say that TP53 is quality control in your cell. Mm-hmm. So when the cell is misbehaving, it checks it out, and if it doesn't like what it sees, it shuts it down. Okay. But if it's mutated, it doesn't do its job. So the cell becomes more and more messed up. And the more and more messed up it is, the less it follows the textbook, like Dr. Desar mentioned, and the more it does weird stuff. Mm-hmm. So that's, again, the importance of that.
Okay, thank you. Next case. Stanley was diagnosed with Waldenstrom's 1 month ago at age 59. His mother was diagnosed with WM at the age of 47 and passed away at age 61. He complains of fatigue, lower leg edema, and non-healing leg ulcers. A physical exam revealed enlarged axillary lymph nodes. His bone marrow biopsy detected the MYD88 mutation, a chromosome 6q deletion, and an LPL infiltration of 50%. His IgM is 30,000 and IgG 2,220. Other labs that are out of range include elevated B2M and LDH, In 2021, he required ICU hospitalization for COVID-19. Another hospitalization was needed for cellulitis in his legs. He's had a recent episode of shingles, atrial fibrillation, and supraventricular tachycardia. His local oncologist recommended he begin bendamustine and rituximab, but he's done a lot of reading online and he's questioning the need to begin treatment.
Okay, I'll get going. A couple of things. The fact that he's got edema, swelling in the legs, makes me wonder about protein leak from the kidney, or maybe something wrong with the heart, that he's having a bit of heart failure. So I would want to consider, I guess a unifying diagnosis could be underlying amyloidosis. So I would want to check those organs, look for protein in the urine, look at the heart function. I would also, on the basis of non-healing leg ulcers, would want to check for cryoglobulin, which is when the IgM kind of sticks to itself and then causes a lot of inflammation, and can cause leg ulcers and other problems. So I'd want to do those tests to look for those those impairments. He's had previous admission to ICU for COVID-19, so he may have sort of residual lung function problems, which could challenge him in the event of an acute situation. I think he's also got, well, he has got very low in IgG levels. And so with that really recurrent history of infection, I think replacement of immunoglobulin either subcutaneously or intravenously may be worth considering. And if we think it's all due to WM, then I think he should go ahead and have some treatment.
I couldn't have said it better. I agree entirely. I'm curious to ask Shirley, what proportion of your patients self-administer SCIG, subcutaneous immunoglobulin, compared to intravenous immunoglobulin? 59, he doesn't seem to like hospital interventions. He could be someone who would be quite amenable to self-administered SCIG.
I think it's somewhat down to availability. Different hospitals offer different, certainly in our practice, we don't do subcut on our site, so we refer to a neighboring hospital. But I would add that there is a massive global shortage of IVIG. So the corollary of that is that people who don't really need IVIG shouldn't be having it because there's a shortage. But yeah, I think either some of our patients do self-administer with just slow injection under the skin.
Yeah.
Makes it much more convenient for them. But it's, I think, 3 times a week?
Weekly.
Weekly.
No, just weekly.
Weekly.
Just
Whereas IVIG is once a month.
once a
usually,
month.
isn't it?
Yeah, and then they come and they get their bloods at the same time as they have their IV. So that's why a lot of patients actually, outside of the COVID pandemic, decline SCIG. But we have a lot who enjoy SCIG and they just sit injecting it while they're watching Netflix over half an hour every week. I think it's interesting, the cellulitis in the legs, you wonder whether that was triggered by the non-healing leg ulcers due to a cryoglobulin is definitely a question, as opposed to diabetic foot ulcers, because they're saying leg ulcers rather than foot ulcers. So I agree with you. There sounds like there's a cryoglobulin there. And then it really is about hearing and taking on board this man's concerns and his reluctance to have treatment, getting him started. I would get him started on his immunoglobulin replacement therapy because I really think he does need that. Even if when his Waldenstrom's is under control and he's been well and infection-free for a year or so, we might be able to stop it. And then edging him towards therapy, because I think it's the therapy of the WM that's going to help reduce all his leg ulceration and his edema. Let's hope it's not amyloid as well. And therapy for the WM will hopefully stop the progression of that.
So just to comment, I mean, I think this patient has an interesting history, and I think that this is where talking to patients and getting a good history really matters, because there's a possibility a lot of things are related to Waldenstrom's, and there's also a possibility the patient has a lot of comorbidities, meaning other problems at the same time. Really important to dissect what's Waldenstrom's related versus what is other. Because if it's the other causes, you can treat the Waldenstroms all you want, you probably make the other things worse. So with this weird infections, had quite a number of things. So, not only had the infection, really struggled with COVID, had an episode of shingles. Just important to make sure that the cellulitis was from the ulcers, that there's not an underlying immune deficiency. Got a weird family history here. So sometimes we'll actually look into that a little harder. For example, there are proteins that stimulate B cells. We're making CAR T cells now against BCMA, which is a protein called BAF binds to. But BAF also binds to BAF-R, it also binds to TACI, and many of those are associated with mutations in that are associated with family histories of B-cell malignancies. It's a little bit like you have an activation of Miracle-Gro again in your bone marrow, which make your cells grow a lot easier, but you can actually get immune deficiencies. So what you want to just be sure about here is that you don't have some underlying immune thing going on, and that's what's precipitating it. And if you look at the Waldenstroms, how much of this is really Waldenstroms versus what is other?
Yeah, I think just picking up off that point, just to make sure, given his atrial fibrillation history and this history of supraventricular tachycardia, the fatigue, the lower extremity edema, the non-healing ulcers, just to make sure that we don't forget that he could have comorbidities, including like vascular, circulation issues as the primary driver, or heart issues that are contributing, that we don't miss while we're thinking about the Waldenstroms. And for some people who have multiple comorbidities, or we're worried about how they'll tolerate the rituximab, either infusing it over a longer period of time, sometimes even admitting them to the hospital if we're particularly worried about their risk of developing of tachycardia, particularly for that first infusion, until we know that they're going to tolerate it.
Final comment is that he's probably quite worried because of his family history. So I would emphasize that things have moved on since his mum sadly passed away. And I would just encourage him to have hope that there are lots of new therapies, and he shouldn't, he should have a better experience overall.
Thank you. I think we have time for one more. So we'll move on to the next. Julia is 66 and has battled WM for many years. She is MYD8 wild type, and her IgM has never been higher than 750. She's been treated several times with various combinations of chemoimmunotherapy and is currently on Brukinsa. Her main concern is recurring soft tissue lesions, which have been treated with radiation. She would like to know if there's any way to prevent them, how she should be monitored for new lesions, and if there are treatment alternatives to radiation.
So I think I guess there are a couple of pieces here. So one piece is that she's MYD88 wild type. One is that she's been treated several times with chemoimmunotherapy, but we don't know how long she has responded each time. And then another piece is that she's developing recurrent soft tissue infections, which I presume means that she's growing through the zanubrutinib. If these are few and far between, then maybe treating periodically with the radiation may be reasonable. If they are becoming more frequent or more larger in size, and radiation to an isolated spot here or there is not sufficient, then it may be time to consider new therapy. This gets back to how long she responded to her prior chemoimmunotherapy. And did she have both a bendamustine rituximab type regimen as well as a proteasome inhibitor, or could we think about, if she only had one of these, could we think about the other?
Go ahead, Shirley.
With regards to the monitoring of these lesions, I think a lot of cross-sectional imaging can pick these things up very well. There's a lot of really advanced imaging techniques. PET-CT is actually very X-ray heavy, so I think using that for surveillance is not advisable. In any case, surveillance, you need to have a strategy for surveillance. If these are easily palpable swellings, then that is a good way of keeping an eye. Whole body MRI is a non-X-ray based technique which can show up soft tissues really well. So I think if there is an informative technique, then that should be the one used in a serial way according to need. And ultrasound can also help. In terms of treatment, as long as Brukinsa is working overall, then I wouldn't, if it ain't broke, I wouldn't fix it. But if it is progressing, then there are a range of potential options that should be considered, not least clinical trials.
I guess I'd make just one or two comments. The first is, again, this is an unusual presentation, an unusual picture, and the question of Waldenstrom's pops back up again. So it doesn't tell us whether they ever checked it in the bone marrow to actually prove that there was bone marrow-based disease or other. But if this has only been in the subcutaneous tissue, this looks a lot more like marginal zone lymphoma than Waldenstrom's, because that's how that behaves. The other thing to remember is that almost all lymphomas, of which this was one, are systemic diseases. The cells naturally travel around. So radiation therapy, we joke and call it spot welding. It's just when you've got a little spot that's giving you trouble, you just kind of blast that one, but it does nothing to fix the bigger picture. So to the point that my colleagues have made is Brukinsa or other therapies are working in the whole body to suppress the disease everywhere. So radiation is only helpful if you've got a problematic or unsightly spot that you want better.
Okay. Well, I'm going to keep going until I'm told to stop. I think we have time for another one. Next case, please. Ruby was diagnosed with Waldenstrom 7 years ago at age 74. At that time, her hemoglobin was 9.8, IgM 2500, and bone marrow infiltration 80%. She received 6 cycles of dexamethasone, rituximab, and Cytoxan, and her IgM dropped to 900 and hemoglobin increased to 12.6. 18 months ago, a gradual increase of IgM was noted, and lately she feels fatigued. Her hemoglobin now is 10.1 and her IgM is 2400. Her mutation status is unknown. She would like to repeat the DRC, but her local oncologist is recommending ibrutinib, so she's seeking a second opinion.
I guess this is a bit more standard garden variety Waldenstrom's. And I think, you know, Ruby with her time to next treatment of 7 years after the dexamethasone, rituximab, and cyclophosphamide, presumably, because I don't know when she actually had it, it's not clear, it's sort of implied that she had it when she was diagnosed. But if it's 7 years from time to next treatment is quite reasonable and understandable, respectable for DRC. I would then be very interested in her comorbidities and what her life expectancy is otherwise, because she's now 81, and I think I would probably opt to go to a BTK inhibitor, and my first choice would not be ibrutinib, but zanubrutinib, given the phase 3 data showing it is better tolerated, and there's only like a 9% cessation of the zanubrutinib because of intolerance compared to 20% with the ibrutinib. So I would hope that that would see her through the rest of her life.
When is DRC preferred over bendamustine and rituximab?
I'm going to suggest that I explain my opinion about that in my slides when I talk soon.
Wonderful.
But leave it to my colleagues to give me their opinions.
Okay.
So I would actually probably, I think it would be quite reasonable to retreat with the DRC, given the length of time that she got out of the first treatment, assuming that she's physically well enough to take it again. It's, I think, fairly mild. The advantage is that it gives her a fixed duration, and it may take her for the next several years. One of the disadvantages of the BTK inhibitors is that they interact with other drugs, and the older that one gets, and presumably the more medical problems that one may have, that it leads the potential for drug interactions with other, let's say, antibiotics or heart medications, what have you. So in her case, because she responded well to the dexamethasone, rituximab, cyclophosphamide, got quite a long time out of it, I think it would be reasonable for her to repeat that.
I would just make one other comment. I think you've heard, the comment that if you have a very long benefit from treatment, repeating the same treatment is very reasonable. If it's much shorter and there are different cut points, because we've got lots of new drugs now, that's a reason to consider something else. But I think, the discussion here was a very long period of time, very easily repeat things. At our institution, we tend to gain as much information as we possibly can at this point. So one of the things that we would do is another bone marrow test so that we could actually be able to test and see what is the mutational status. We would make sure there's nothing lurking in the background that could be damaged from previously, just that sets us up for making a wisest choice moving forward. So it's one of those knowledge is power opportunities. So if, again, the patient is willing and considers that as another thing to do, we would typically repeat a bone marrow before we start treatment.
Yeah, I would definitely do a bone marrow. And I think since there's no clear-cut answer, I would say, look, what does she prefer? Does she would she like a defined period of therapy, or would she prefer, is she happy to take tablets long-term, which can eventually lead to, side effects, etc. So I would kind of really try and give as much information about the options. Well, she knows about DRC because she's had it, but I'd just bring her in and see what she prefers, because it's not clear which is better.
Yeah, as a patient, I like that. Next case, please. Donna was recently diagnosed with Waldenstrom's at age 66. Her primary symptom is increasing fatigue over the past 6 months. Laboratory studies showed a hemoglobin of 10.2 and IgM of 2100. A PET scan showed an enlarged heart, thickening of the esophagus, and slightly enlarged mediastinal lymph nodes without skeletal lesions. A bone marrow biopsy showed 5% lymphoplasmacytic cells and amyloid deposition. An abdominal fat biopsy was positive for amyloid, and additional studies confirmed systemic amyloidosis. She's negative for the MYD88 and CXCR mutations. She feels well and seeks a second opinion to learn if she needs treatment right away.
So she appears to have systemic amyloidosis, meaning amyloid throughout her system, that it's involving the heart. It looks like it's involving the GI tract. So here, again, I think this is one of where I would choose a regimen that straddles typical treatment for Waldenstrom's with what is often used for primary amyloidosis when it's seen sort of more myeloma-like. So here again, I think with amyloid that's more myeloma-like, we often use cyclophosphamide, bortezomib, dexamethasone in combination with a drug called daratumumab. In this case, because she has Waldenstrom's as her underlying disorder, not a myeloma type picture, I would substitute the DARA with rituximab. So rituximab, cyclophosphamide, Velcade, and dexamethasone.
In terms of whether she needs treatment, she is feeling well, but she's getting increasing fatigue. And I think the presence of amyloid worries me. And I think it's inevitable that her organs will decline. So I would actually be encouraging her to go ahead and start treatment so that we kind of circumvent that deterioration. I mean, generally, if you start treating amyloid, ideally it should work quickly and you should get a deep response. So I would consider actually something like bendamustine, Velcade, and rituximab therapy. BTK inhibitors don't have a great reputation so far in amyloid. So I'm not sure. I don't think I would go down that route. And I would, if she gets a good response, I would consider consolidating it with an autologous stem cell transplant. But I think the first thing is to treat the disease, but make sure we know what her vital organs are like as a baseline. There are also some clinical trials of amyloid busting drugs, antibodies. So if she can access that as well, that would be something I would look at.
So just to point out, I think my colleagues have already given all the right answers, but this is a bit of a different circumstance. And I think it's important that the amyloidosis is the problem here. The underlying Waldenstroms, you could argue 5% protein's not that high. You could just let that be. But this protein is super sticky and it's sticking in tissue. And that's what's going to put the patient's life at threat. It's depositing itself in the esophagus, in the different tissues, in the heart, and all of those are potentially the real problem, not so much the Waldenstrom. So the discussion you're hearing about the treatment is going after the cells to kill the cells, to stop them making the protein so the whole problem doesn't get worse. Or, as Dr. Desai said, changing the structure of the protein so that the protein, again, doesn't stick in the same way. But the important message to take home here is the amyloidosis is the danger, not the Waldenstroms.
Is the fat pad biopsy the best way to diagnose it?
I think in our practice, yes, it's not perfect. And often if you did a bone marrow at the same time and you stain the bone marrow, you can pick it up in one of the two places. But a fat pad is easy to do. It's just a little needle under the skin. It's done in just a few seconds. And it has about, I think, an 85% likelihood of picking it up.
I noticed she had a very low percentage of infiltration in her bone marrow.
Correct.
Is that still a diagnosis of Waldenstrom?
So you could get into a whole debate of whether or not this is Waldenstrom's or not, but I think the fact that amyloidosis is associated with it, I think you can call this disease. So the reason we make a fuss about smoldering versus Waldenstrom's or versus MGUS is to try and work out when you need to do something. In this case, with the amyloidosis giving the trouble it is, you need to do something, not so much for the Waldenstrom side, but for the protein side and what it's doing.
Okay. And one last question. When is a PET scan done?
So PET scans are generally, so just reminding people what a PET scan is. A PET scan is a CAT scan with a sugar tracer. And the sugar tracer goes to cells that are sucking up sugar because they're very active. And then it allows them to marry the pictures from the CAT scan, which is an X-ray, pretty much with the images where the sugar is being used. So why is that useful? If you have cells that are super active, you can see where they are relative to structure. So the most useful thing is there an area that is transformed, got more aggressive? That would certainly be a way to pick it up. Or if the disease is in weird places, it helps you tell that. In this case, it's not the best way to pick up on the enlarged heart, but it did. So the fact that you picked up an enlarged heart on a PET scan means that heart is not in good shape. So bottom line is that's why this needs close evaluation.
And I think probably follow up with a cardiologist who is familiar with amyloid and can assist with management would be very helpful in this case.
Thank you, doctors. We really learned a lot. I know I did.